Good evening, everyone, and welcome to the 2013 MedStar Women's Health Webcast. We're live in the teleconference center of the Curtis National Hand Center at the MedStar Union Memorial Hospital. I'm Lisa Robinson from WBAL-TV, and I want to welcome everyone for joining us tonight. You are watching us live via Ustream, accessible through the MedStar Franklin Square webpage and Facebook page. You can feel free to post comments to us using hashtag MedStar Women's Health on Twitter, on our Facebook page, or in the chat room. And you can post comments and ask questions. You can post your questions to some of the top experts in their fields in the region, and they are here in front of you. Meet our panel from MedStar Franklin Square Medical Center. To my left, gynecologist Dr. Lee Matlaga from the MedStar Franklin Square Women's Health Center. And from the MedStar Cancer Network, Dr. Kristen Fernandez, a breast surgeon and the director of the Breast Center. Next, from the MedStar Heart Network, is Dr. Shriyam Pad, Chief of Cardiology. Welcome. Dr. Mahfouzul Khan, he is our endocrinology expert. Dr. Jamie Walters is one of our gastroenterologists in the new center at the MedStar Franklin Center. MedStar Franklin Square, rather. And to the far right on your screen is orthopedic surgeon Dr. David Gold. Thank you all so much for being here. We also have in our studio audience Michelle Asaroff, a women's health nurse navigator. Thank you also for being here. So here they are. Use hashtag MedStar Women's Health to send us your questions. Let's begin. Across the board, Dr. Matlaga, healthcare seems to have a constant shift in surgery when it comes to minimally invasive procedures. Why is that so important?
I think it's so important because it's important to realize that our patients are, active members of the workforce. We want them to have safe surgeries. We want them to get back to their daily activities, whether it be raising a family, whether it be, running a company. But with minimally invasive surgery, we think we can have wonderful results with small incisions, less pain and bleeding, and get people, up and back to their normal lives sooner. So if we can do the same thing and have those improvements, it's tremendous for patients.
And Dr. Fernandez, and when it comes to breast surgery?
Much the same way. Still, so many women come to my office and think, I have breast cancer, I need to have my breast removed. And that's so far from the truth. We're really able to offer the majority of women what we call breast conservation therapy, which means doing a lumpectomy followed by radiation therapy. And that, as Dr. Matlaga spoke of, gets the women back to work faster, back to taking care of their families. It's less painful and it's less disfiguring.
Mm-hmm. All right, let's move on to heart disease. Dr. Pad, why is it considered the #1 killer of women?
Well, it's a conception amongst many women that heart disease is not common in women, which is actually a misconception because heart disease is still the #1 killer in men and women. The only difference is that in women it tends to show up 10 years later than men because of the protective effect of estrogen, but in postmenopausal women it catches up very quickly. And the same risk factors that apply for men apply for women. There's no big difference. But there is some difference in the way women show up with heart disease. Typically, men have chest pain or chest pressure, which is, the typical thing that we hear about heart attacks. But women tend to have more of fatigue, shortness of breath, maybe pain in the neck or arm, but not typical chest pain. So they sometimes delay the care they get from their cardiologist or even going to the ER with heart attacks.
Okay. All right, I skipped ahead a little bit. I wanted to go back to our first two doctors and some questions about the minimally invasive surgery. And I want to invite the audience right now, if you have questions for Dr. Matlaga and Dr. Fernandez when they were talking about the benefits of minimally invasive surgery. Let me get my microphone. Do we have any questions? Raise your hand if you do. And do we have any questions from the audience at home on Facebook or on Twitter? No? Okay, we do have a question.
So one of the things I hear about with regard to breast cancer, is preventative mastectomies, or women who have the gene to, you'll have to explain this far better than I know because all I hear is what Angelina Jolie is doing or whatever, but doing these preventative kinds of things because of their fear of getting breast cancer. And I'm just wondering is why would a person, it just boggles my mind that a person would do that when there's options like you just mentioned that are much less invasive.
So many women overestimate their risk of breast cancer, and I tell women who come in and say, both of my grandmothers died of breast cancer in their 80s, I just know I'm going to get it. And I say, 1 in 8 women who lives into their 80s will get breast cancer, and the #1 cause of death in women is heart disease. So as Dr. Pad was saying, it's sometimes it's very overestimated. However, there are a group of women who have a gene mutation called a BRCA gene mutation, and that was the case of Angelina Jolie, which got so much press, which was good in some ways, but scared a lot of people in other ways. People will say to me, do you think she made the right decision? Well, I start with, I'm not her doctor, so I don't know her specific situation. But a woman with a BRCA1 gene mutation has an 87% lifetime risk of getting breast cancer, up to 87%. So that's much higher than that 1 in 8 women who live into their 80s. And those women who have the BRCA mutation tend to get cancers much younger, in their 30s, 40s, early 50s. So the prophylactic mastectomy, or removing the breasts with no evidence of breast cancer, is a good option for them. There are other options for monitoring these women, but the best prevention for those women is the mastectomy. So it's not for everyone, though, and for women who don't get mastectomies, we recommend getting yearly MRIs of the breast and following them that way. I explain to my patients it's not a way to prevent breast cancer, but it's a way to diagnose it at its earliest, smallest, most curable stage.
I would like to also ask, you all have to work together quite frequently because things that happen with the breasts go hand in hand with other gynecological issues. And tell us a little bit, can you talk a little bit about that?
Well, when we do our history, when we meet a patient, we're always asking about the history in the family, about the self-breast exam, and often we'll elicit a history which is concerning, such as someone in the family who was less than 50 that had breast cancer, someone in the family who had ovarian cancer, a man in the family that had breast cancer. And so if we identify someone who's high risk, we might offer genetic testing through our genetic counselor or through seeing Dr. Fernandez or the oncologist, Dr. Taviano. And what many patients don't know that I just recently learned, and I thought was wonderful, is that we don't generally charge for the genetic counseling. We think it's such a good service that patients can come see us and really have like an in-depth discussion of their genetic risk without necessarily worrying about the insurance benefits of that. You know, certainly, you know, mammograms and examination and that might be different, but I think it just shows that we think that prevention is really important and women's wellness is such an important part of our care.
Let's go to one of the questions that we have. Sarah asks, what are the causes of your period coming late or not coming on time that has been negative during fertility treatment?
Could you repeat the question?
Sarah wants to know, what are the causes of your period coming late or not coming on time and that has been negative during fertility treatments?
Well, the way I understand the question is, you know, if you're an infertile patient, why are you concerned if your period isn't coming on time? And when we talk about fertility, we talk about someone having problems if it's taken them a year to conceive or more, and 1 in 10 couples suffer from that. One cause is not ovulating, when you don't have a regular period. And if you're not releasing the egg, then it's hard to have the fertilization occur, which is the beginning part of the pregnancy. So during fertility treatments, that can be affected because they're manipulating the hormones. They actually give short-term menopause shots to sort of stop the cycle and recreate it to extra ovulate, or just really to encourage a process that isn't happening on its own. So when people come in and they tell me that their periods aren't normal and they're having a problem, we rule out medical causes such as diabetes and thyroid issues. A hormone from the brain called prolactin can be in play. So she may be asking about, why am I not having my period regularly and I'm trying to get pregnant? Or she may be saying, I'm in treatment, why don't I get my period? So that's why I'm going to give you the 2 answers.
Okay. Do we have any questions from the audience? Okay.
Sometimes I'm not completely understand. So my question is, what some the symptom of heart disease in women? Exactly, I want to know.
You wanted to know what are the symptoms of heart disease in women? Okay, well, I guess
Well, there's a lot of commonality between men and women. It's not as if they're polar opposites. The common symptoms will be chest pain or chest pressure if you're having blocked arteries. But the difference comes in, number one is, when do women start having heart disease versus men? Women tend to have it 10 years later. So men typically start having symptoms in their 40s. Women will be in the postmenopausal in the 50s and 60s. And the second difference is that symptom-wise, women tend to have less of chest pain and chest pressure. You know, we hear about in the movies someone having severe chest pain. That's more common in men than women. Women tend to have more subtle, what we call atypical symptoms, and that's why they delay the care. So they might have fatigue, suddenly feeling like they've run a race when they haven't. Or they may have shortness of breath rather than chest pain. So what they're able to do before, walk up a flight of stairs, now they're getting very short of breath while they're doing that. They don't get the chest pain. Or they may feel symptoms in the neck, jaw, or arm rather than just the chest, or even the back. So there's some subtle differences. And because of the difference, and because people are not very well aware that these differences occur, so women tend to come to their doctors later, so the disease has progressed more by the time they come and show up. When they come to the emergency room with a heart attack, it's actually been delayed by many hours because of these differences in symptoms.
Wow. So how is heart surgery recovery longer for women than it is for men?
Not recovery itself, but the prognosis is different. So the data suggests that women who come with a heart attack, the first year, their rate of death is much higher in women than men. The recovery after surgery, I'm not really sure that there's a big difference, but the rehabilitation tends to be a little bit longer in women than men. So I'm not sure that their overall life expectancy has changed, but they do take a little bit longer to recover.
Okay. We have a chat roll guest that's asking, how can we participate in free genetic testing? And that's for you, Dr. Fernandez.
So you can call us at Franklin Square, at MedStar Franklin Square, and probably the best number would be 443-777-6500, and we can get you information on contacting our genetic counselor. There's also a link on our website for free genetic testing that you can download the questionnaire and fax it or mail it to us. So either way.
It would be important to add that there are some patients that will have cancer that don't have an abnormal gene, so it's important to make sure that people are coming in for their regular care as well and seeing a specialist, if necessary.
What other kinds of minimally invasive surgeries procedures are that being done for women?
Well, when we talk about GYN issues, we often think about bleeding and fibroids. I think one of the most minimally invasive are people that are able to do medical management. So you want to have an open conversation with your doctor about all the different options. For some people, birth control will help them. Ablations exist. There are many different types of ablations to burn the uterine lining. That can be an outpatient procedure, sometimes done in the office, where it really helps people with their bleeding, and 95% of people have much lighter periods. But one of the hot topics is robotic surgery, which I do perform with removing fibroids or uteri. And it's wonderful. Patients can actually go home the same day from hysterectomy and have a 2-week to 4-week recovery, when it used to be that they would be in the hospital for 3 days, if not a week, after surgery and have a really disfiguring scar.
Is that more precise?
I think it is precise in the sense that they're very small instruments. The small graspers and scissors that we use during the procedure are maybe just 5 millimeters in length at the actual tip. The incisions are all less than 1 centimeter. So people can really get back to work quickly. And although we talk about work, that really just shows that they're going to be feeling themselves, they're going to be feeling better, they're going to be using less pain medication, and they're going to still get wonderful surgery.
And before I move on to one more question, does a hysterectomy go hand in hand with breast surgery?
Not always. We keep talking about this gene mutation in women who carry this abnormal gene. Less than 15% of all cancers diagnosed today are due to a gene mutation. So it is definitely the minority. But for those women who have a gene mutation, often they'll get their ovaries removed, tubes and ovaries removed, along with their breast.
Okay, wait, I'm going to go back and ask you about the Da Vinci technology. Can you explain that?
So Da Vinci is a robotic-assisted laparoscopic procedures. So laparoscopic procedures use very small incisions, 1 centimeter, sometimes half of a centimeter, which allow us to place instruments inside the body and to operate. And the robot's wonderful because the movements are very lifelike. So they have 7 different types of movement. So as opposed to some of the sort of direct left, right, up and down movements, it's very fluid.
Are we looking at that now?
Yeah, we're looking at the robotic procedure where I'm sitting at the console, operating. That's the tube and the ovary on the left, the uterus on the right. And this is a patient that had large fibroids, which was able to have a hysterectomy. She was able to retain her ovaries, and we were able to remove the uterus and the fibroids, where she went home the same day, and she would have the short recovery. This has been shown to have tremendous results, actually also within cancer surgery. It's really beneficial to patients who are overweight because of the little incisions, because if a large incision is to become infected, it can really be debilitating for a patient. There's actually something called a wound vacuum that patients can have to have if they have a severe infection in the incisions. So these little incisions are really helpful.
Okay, and on the screen, the benefits are less pain, less bleeding, and same-day discharge.
So I've had people go back to work after 3 days. I don't recommend it, but I think it's that you could feel that you could go home and in cases not have narcotic pain medicine, just take Advil or be able to go back and sit at a desk job. Just shows that, you can have surgical options that really aren't as intense or restricting as they were in years past.
Okay, let's go to some of our Twitter questions. Tiffany L. Spicer asks, what is the reason for having a period for 3 weeks while on birth control?
So usually birth control thins the lining of the uterus, and that's generally considered to be breakthrough bleeding. So birth control is designed to be a balance of estrogen and progesterone, and there are different doses. There are low-dose pills, 10, they go up to 50 in the estrogen component. So I generally tell people that if you've recently started your birth control, this is a normal effect and give it 3 months. But if this is something that you've been on the pill for a while, you've got to exclude other causes like cancer or infection, and consider a different method, a different type of pill maybe, or just something different.
Okay, and I want to remind everyone in the audience, if you have a question, just raise your hand. We do have another question from Twitter. What are the causes of precordial catch syndrome? Am I saying that right? Nobody.
I'm not familiar with
Precordial catch syndrome?
I think this is a cardiac concern, is it?
Precordial?
Precordial
catch syndrome.
Or precordial
Precordial.
chest syndrome?
Precordial catch. Maybe it's precordial chest syndrome. Perhaps that's what it's supposed to say. No?
I don't.
It's not me.
If she can ask us a follow-up question
Yeah, so we can
with
get a
more
follow-up
detail, we want
question.
to make sure we're on the same page.
Right. Do we have any other questions from the audience?
Hi, this one's for Dr. Pat. I was wondering if you could maybe talk a little bit about statins. I understand they have new guidelines
Oh,
for
my
using
goodness.
statins for cardiac patients, and I guess
It's
my
just come
concern
out.
is
I haven't even been able to digest it yet. But it just came out this week, but there are going to be some changes. Well, let me step back a little bit. We all have to be aware of our cholesterol. And earlier we had some guidelines of what your good cholesterol should be, what your bad cholesterol. I think those guidelines have not changed. They're pretty much the same, that if you have a bad cholesterol of LDL, more than 190, it is bad, so you've got to do something about it. But I think what they've changed is that we don't have to be pushing the LDL too low anymore. It has to be patient specific rather than run after a number. We used to run after this number of 170, some people. We don't have to be doing that. And they've identified stroke as another risk factor for heart disease, which was not part of the guidelines before. And I think in general they broadened it so that I think more people will land up by these guidelines needing statins. I think we should just add it to the water. It'll save us all this trouble. But there are going to be some changes, but it's so new, we still have to digest it. The community has to talk about it. So we haven't really figured out what to do. And I'm going to wait. Maybe it'll take a year for us to really understand what changes will come about. But right now, we're still following the old guidelines.
All right. Dr. Khan, with 59 million Americans having thyroid problems, why is that?
I think if I knew the answer to that question, I might be somewhere else. But thyroid diseases are common. I'll backtrack a little and probably just talk about the function of the thyroid hormone. Thyroid hormones do have functions, wide-ranging functions throughout the body. And they do have an important role to play in regulating somebody's energy level, their weight, their mood, as well as reproductive health as it applies to women's health. Thyroid dysfunctions, as you mentioned, are common. But the caveat is that they tend to be 5 to 8 times more common in women than men. The reason for that likely is the fact that most thyroid diseases, whether it's thyroid hormone abnormality, and there are two main ones. One is the underproduction of thyroid hormone, which is hypothyroidism, or overproduction of thyroid hormone, which is hyperthyroidism. And the other broad category are the formation of nodules or thyroid nodules. Most of these thyroid problems, we believe, are autoimmune in nature. Mm-hmm. And as with many other autoimmune diseases, may that be rheumatoid arthritis, scleroderma, lupus, autoimmune diseases tend to be more common in women than men. So I suspect that the reason we see a discrepancy in the distribution of thyroid hormone abnormalities as well as thyroid diseases in general probably has to do with that aspect of it.
All right, and a lot of times, this is something as women get older, they're always checked for when they go to the doctors. And if you're not, I guess it's something you should be, you should ask your doctor to check you for. And one of our Facebook visitors wants to know, what are some symptoms of thyroid disorders?
Sure. It's sort of a broad question. You know, usually what I like to explain to my patients that you can sort of think of thyroid hormone essentially as if it's a spark in an engine or in a furnace, so to speak. So it's not the actual source of energy, which of course, as we know, is what we're eating. But the thyroid hormone acts as a catalyst in terms of using that energy and utilizing it properly. So if you think of thyroid hormone abnormalities, and again think of those two broad categories, one is hypothyroidism or low thyroid function, and the other one is hyperthyroidism or overactive thyroid. Patients who have hypothyroidism tend to have symptoms that is, if you will, just sort of turning the thermostat down. So folks usually feel cold, tend to put on weight, feel fatigued, tired, mm-hmm. Might have issues with swelling either around their eyes or in their legs. On the other side, patients with hyperthyroidism or overactive thyroid or overproduction of thyroid hormone tends to have symptoms on the opposite spectrum. They will still feel fatigue, but usually there are other symptoms such as palpitations or fast heart rate. Oftentimes there might be a risk for having irregular heartbeats, high blood pressure, as well as weight loss, increased appetite, excessive sweating.
And I'm just chuckling to myself because this could be so many different things.
Which is very true, and we do see a lot of patients or a lot of folks that do come in and see us or probably go visit their primary care physician. Nowadays, in the age of Google, if you type in your symptoms anywhere, you can actually get a differential diagnosis, which frequently involves thyroid disease. So it is so true because many of these symptoms, such as fatigue, putting on weight, change in energy level, mm-hmm. many of those symptoms can be manifestations of other medical problems, whether it's heart or lung problems, obstructive sleep apnea or poor sleep, depression and anxiety. So diagnosis of thyroid disorder usually requires a careful history taking and ultimately the measurements of thyroid hormones in the blood work.
Okay, we do have a chat question, but I want to ask you, when you go to the doctor, I mean, at what point do you say routinely, check my hormones, check my thyroid? What do women need to do when they go to the doctor when it comes to this issue to make sure they're checked?
I think probably the most important advice that I can give is to actually report all of the symptoms that one is experiencing. And I find in my patients to actually keep a diary of symptoms so those things are brought up, because frequently one walks out of the physician's office and mm-hmm. thinks, oh gosh, I should have told them that I'm feeling this way or that way. And then, as I mentioned, the primary care physician or whomever they happen to be seeing at that point will hopefully work through the broad possibilities. And certainly if there is a need for it, checking thyroid hormones usually are pretty easy.
Okay. Here's a question from a chat question. 3 of my 5 aunts have thyroid disease. Does that mean I will get it at some point?
Good question. So again, you see that family history of it, and frequently You do see patterns in the family where female family members are affected more commonly than male family members. The most common thyroid disorder that tends to run in the family is something called Hashimoto's thyroiditis, which again is an autoimmune thyroid disease that predisposes an individual to having low thyroid function or hypothyroidism. So I can't say definitively that you are going to get it, but certainly that raises the suspicion, and if one is experiencing some of those symptoms that we described earlier, that may be a reason for earlier screening.
Are there effective treatments for thyroid problems?
Absolutely. It's probably one of the easier conditions to treat, in my opinion. There are effective thyroid hormone replacements for folks who are actually hypothyroid or their thyroid hormone levels are low. We do see patients who have overactive thyroid or hyperthyroidism. Usually those folks are much more symptomatic in terms of having palpitations. Sometimes we even see patients who are in the hospital because they have congestive heart failure as a result of their heart rate being so high and being in arrhythmias. And there are effective treatments for that as well.
Okay, good news there.
Yeah.
Let's move on to Dr. Walters. What are the most common complaints that you hear from women between 35 and 65? Irritable bowel syndrome. Why is this?
So we don't really know why it is. Just to backtrack a little bit, irritable bowel syndrome, or IBS as we call it, is a condition that is a functional GI disorder, which means it's not a disease, which is the good news. It's not a cancer, inflammation, or something that's going to cause harm to your body. But unfortunately, it's something that causes a lot of symptoms. Most often women experience abdominal pain associated with diarrhea, constipation, or both. It can actually affect up to 20% of the population can have symptoms over their lifetime, and 2 times more likely in women. It's actually the most common reason people to come see me in GI clinic. There's good news and bad news. The good news is that there are a lot of treatment options available. The bad news is there's not one pill that I can give someone to make them feel better. I wish I could. What we do is we would sit down and talk about all the symptoms that you're having, and things in your life that can contribute to IBS include stress, maybe a food intolerance that someone's developed, an infection that they recently had, they have maybe had surgery on their gut or anywhere else in their body. And all these things can predispose you for developing IBS. It's more common in the younger age group, but can also prevent throughout life. And the good thing is not everybody that comes to see me needs a colonoscopy for this. There are some important things that I'd like to point out that I would think that you would need a colonoscopy, what we call red flags that would include bleeding, or if somebody's having weight loss, a family history of colon cancer that I may be worried about, things like that. But it's definitely more common in women, and there are options to help.
It can come and go, and there are certain triggers.
Yes, and again, not every person has the same triggers. Some people, I have identified certain things in their diet that may trigger their symptoms. Stress, depression, anxiety, and other medical conditions can, contribute to their triggers. But that would be something that we would work out in clinic.
All right, and next, a Facebook question. Let's get. I keep hearing about Crohn's disease. How do I know if I have that?
That's a good question. So Crohn's disease is a condition called inflammatory bowel disease. And I should point out that this is extremely different than irritable bowel syndrome, although it may be confusing because they may present similarly. But things that I mentioned to worry about would be weight loss, especially if it's a younger patient who's just not gaining weight, especially if they have bleeding or persistent diarrhea. And again, it's an inflammatory bowel condition that we would need to do an endoscopy to diagnose. We're not really sure exactly what causes inflammatory bowel disease. Recently, there have been a lot of genes that have been associated, but also infection and genetics play a role. So it's something that we would like to diagnose early. There are good treatments available, but it is a chronic, lifelong illness.
Okay. Can IBS lead to cancer if it's not treated?
So no, that is an important distinction to make. Irritable bowel syndrome cannot lead to cancer. There's no inflammation involved, and it's actually not considered a disease. It's considered, like I mentioned, more of a functional disorder, which means the gut just isn't moving properly. It's not a structural, there's no mass, and there's no, like you said, cancer identified. So it does not affect someone's length of life.
Okay. How do you diagnose IBS?
So again, I wish there was an easy way. I think it's just You know, we mentioned sort of a diary of keeping track of your symptoms and how you're feeling in a day, and just talking to your primary care provider or a gastroenterologist to sort of identify what's going on. There are certain societies that have put out criteria, so it's actually diagnosed by history. You don't necessarily, like I said, need a colonoscopy. You don't necessarily need any lab tests. It would just be a sit-down discussion with a physician to determine if you have it or not.
All right, I just want to check in the audience if we have any questions, and we do. Okay.
I'm actually going backwards. Sorry. I have a cardiac question and a thyroid question. Do you think that women are born with more accessory pathways than men, is my cardiac question. And for my thyroid question, how come one thyroid test can be off, but the other two can be normal, but the patient is still not diagnosed with either hyper or hypothyroidism? Like say their T4 is off, but their other two are normal. How come that happens?
I can go first.
Okay.
So typically when we're doing biochemical testing for thyroid function, we're typically checking 3 different thyroid hormone levels. One is the TSH, which is thyroid stimulating hormone. It's actually not a thyroid hormone, it's a pituitary hormone that stimulates the release of actual thyroid hormones, which are the T4 and T3. And it's the actual it's really the T3 which imparts all the functions that the thyroid hormone is supposed to have throughout the body. The T4 is the storage form, which is the predominant form of thyroid hormone that circulates in the body. And all throughout the body, the individual cells take up the T4 and convert it from T4 to T3. And T3 is essentially the rocket fuel that does what it's supposed to do. So, and there is a fine interplay between the two. Really, for most individuals, the TSH is the best measurement to know whether or not, for them, the thyroid hormone production is adequate, too much or too little for that matter. Because there is a feedback loop, as it is everywhere within the body, a check and balance. I guess our political system can learn something from the body. But essentially, depending on where you are on the thyroid hormone production process or thyroid hormone, where your thyroid hormone level is, the pituitary responds and decides how much TSH is going to put out. So for an individual, the best way to really know what the thyroid, where they are on the spectrum of thyroid hormone production, it's really the TSH. I will mention that frequently for women who are on birth control pills, or even sometimes women who are going through normal menstrual cycling, especially for pregnant women, a lot of times because of changes in estrogen level and how the estrogen changes one of the carrier molecules or binding globulins for the thyroid hormone, you can see changes in one as opposed to some of the other thyroid hormone profiles.
Okay, Dr. Pat?
Are you particularly asking about WolffParkinsonWhite syndrome? Is that the accessory pathway you're concerned about?
Any pathway that would show any kind of abnormal rhythm?
In a broad spectrum, no, there is no gender specificity for arrhythmias, except for some genetic linked causes of, especially things called ventricular tachycardia. Some of them are X-linked, which is more prevalent. It's basically for men. It happens in men only. But in a broad way, no, there is no gender specificity for arrhythmias.
Okay. Let's move on to Dr. Gold over there in the end.
Waiting patiently.
You know, as women age, bone health is more and more important. Talk a little bit about what happens to a woman's bones as she gets older.
Well, in everybody's bones, both men and women, we lose bone mass. For women, after the age of 50, after menopause, that decrease in bone mass happens very quickly. The problem is, as the bones get thinner, there's more propensity for fractures. So one of the things that we deal with in women in bone health is trying to prevent those, what we call fragility fractures, or fractures from having thin, porous bones. So the medical treatment of osteoporosis has certainly advanced quite a great deal over the last couple of years to try to prevent that loss of bone health. But despite that, we still see a lot of fractures in our older patient population, more so in women than in men. Fortunately, there have been a lot of advances from a surgical standpoint in trying to repair and fix those fractures to allow them to heal and to get a good functional recovery.
And women, I mean, particularly why women experience this more than men?
It's probably hormonal. Probably has to do with estrogen having an effect on bone mass. I think one of the other reasons that we see so many more osteoporotic fractures in women is women live longer. They have about a 10-year longer lifespan. We tend to die off a little bit earlier, so we certainly see a lot more older women with fractures.
Can you talk about how making sure that your bone strength, how we can strengthen our bones as we age? Is it through weightlifting? Is it through calcium? What are the things that we can do early on?
There's some simple things that we all can do, and one is exercise. And it has to be a weight-bearing type exercise. The old line that if you don't use it, you lose it is really true. And so one of the things that we see in people that just do things like cycling is they lose a lot of bone mass. So it has to be where you're putting weight on your skeleton. And that can be a walking program or anything like that. Weightlifting does not really help to prevent osteoporosis. Certainly taking calcium and vitamin D is very important. I think the medical doctors are much more cognizant, and I see lots of my patients that are now on vitamin D routinely. They have been shown to help, taking calcium and vitamin D, and those are simple things that all women probably should consider doing. If there is a concern about osteoporosis, if someone has one of these types of fractures that we see, they probably should have a bone density test. It's a very simple test that measures the degree of osteoporosis. And if they fall into that category that they do have osteoporosis, they probably ought to see either their medical physician or an endocrinologist to consider an additional medical treatment.
What are the minimally invasive procedures that can be done for hip replacement? Is there?
There have been a tremendous amount of advancements in the last decade for minimally invasive joint replacement surgery. And minimally invasive to us doesn't always mean a smaller incision. A lot of times it means doing less internally as far as interrupting muscles and tendons to try to get people back to their activities quicker. So we're now not talking about osteoporosis, but we're talking about arthritis. And arthritis means not a wearing away of the bone, which is what osteoporosis is, but a wearing away of the cartilage. And when the cartilage deteriorates, that's the cushioning in our joints. And when it gets severe, we have what's called bone on bone, and then patients will oftentimes come to me. Most people know that as we get older, we get more people get osteoarthritis, but what they don't realize is that 60% of all osteoarthritis sufferers are women. It is a much more common problem in women, and it affects millions and millions of people. Fortunately, there are some of these lesser invasive techniques. For knee replacements, women are oftentimes very good candidates for what we call partial knee replacements, where we only have to replace the small part of the joint that's worn out versus doing a complete or what we call a total knee replacement. And I've done many knee replacements, partial knee replacements on women, the advantage being smaller incision, less surgery, a better functional recovery, and a quicker return to activities. With regards to hip surgery, oftentimes women are good candidates for minimally or less invasive surgery. They have a smaller muscle mass, so we can make smaller incisions. We can do more what we call muscle sparing surgery, which certainly leads to a quicker functional recovery.
Okay. We have a Facebook question. What is the possibility of getting osteoporosis from using Depo-Provera?
I think that might be one of the questions that we can ask our OB people.
Well, they have concern with osteoporosis if you're on Depo-Provera as a young person in your teens, maybe early 20s, for over 2 years. But the OBGYN Society, the American College of OBGYN, they don't recommend that we require people to stop Depo-Provera or even that a bone density study be done. They feel like this is mostly reversible and that it's a counseling decision between the patient and the doctor. So we always want to tell our patients that at the 2-year mark, there is some evidence that you could be affecting your bone health. We have many patients that then decide that they would like to just try a different method for 6 months to a year, but there are people for whom the injection, Depo, is by far, in a way, the best thing, and we're able to prescribe it as long as they have understanding, and we'll offer the bone density if they'd like to check that.
from Twitter, is there really a difference in the knee implants used in women?
That's a very good question. There are some medical supply companies that market the so-called women's knee. There have been a number of studies that have shown that that really does not make a difference. Everybody's knee is a different shape and a different size. What I do is what's called computer navigation for knee replacement. And in our operating room at Franklin Square, we have a very fancy computer setup that very accurately measures everyone's knee specifically, so that I tell my patients, you will get the right size components that fit your knee. And whether it's a man or a woman, they come in all shapes and sizes. And it has to be fit very appropriately and very accurately. And that's why I feel that using this computer navigation technology, which really has come along in the last 5 to 7 years, has really made a vast improvement.
Okay. We have a chat question. Is the heel scan test the same as a DEXA scan, and what is the difference?
There are different bones that are checked to detect bone density. Most of the tests look at the hip area and also the spine, because those are the two of the critical areas that we see these fragility fractures. I am less familiar with the heel test, and I don't know if you can comment on that or not.
Sure.
But go ahead.
So I think that what Dr. Gould mentioned is right on in terms of saying that osteoporosis and fragility fractures, frequently the fractures of concern are really in the hip and spine region. And the heel scan can often be used as a screening test, but ultimately it's the full-on bone density scan, which is the DEXA scan with the hip measurements in the hip spine region that are used for diagnosing osteoporosis and also for following somebody on treatment.
Okay. We also have in the audience tonight, in our studio audience, Dr. Jiha Cambodge. Okay. And you're a pain management expert with MedStar and Franklin Square. And I'm glad you're here because we have a question for you. What are some options for pain management for long-term back pain? That's a question that just came in.
So we believe in a multimodal approach to pain management, which includes medicine adjuncts such as anticonvulsants, antidepressants, muscle relaxants, and topical medication. In addition to that, my partner, Dr. Hansen, and I we, strongly believe in physical therapy, along with interventional pain management interventions. So that would be lumbar epidural injections, transforaminal epidural injections, and trigger point injections, for instance.
Okay, and let's go to your colleague sitting next to you. And you're familiar with a number of programs and that are available to members of our audience to help with all of the things we talked about.
Yes, in my role as nurse navigator at MedStar Franklin Square, not only do I direct people, not just women, but my callers to providers, as those here on the panel, among others, our services and classes that we have available, whether it's the bariatric program that callers may be interested in there, pain management. Very often it's multidisciplinary. A caller may be contacting me describing abdominal pain, and after some questions, it may be, well, maybe starting with your primary care provider is the direction to go, but then they may end up going to see Dr. Walters or Dr. Metlaga.
And I just want to know, what are some of the options for long-term back pain?
Anticonvulsants, for instance, have been shown to be very, very good in treating long-term back pain, in addition to antidepressants, because there's always a mental component to pain, and some of the antidepressants have been shown to be very effective. Muscle relaxants are certainly an option. We believe in functionality as opposed to achieving a pain score of 0. We believe very strongly that a multidisciplinary approach, including physical therapy, adjunct medications, and some of the interventions that we have, would achieve the best quality of life for our patients.
Okay, great. Well, now that we've heard from all of our experts, we're continuing to take your questions and online, and we have some right now we're going to go to. Is there any best treatment for a ganglion cyst, or is it a waiting game?
I think that's my question. A ganglion cyst is a collection of fluid that can happen in lots of different areas. Most commonly it's around the wrist, but sometimes they can happen in the fingers or around the knee. The old line, they used to be called Bible cysts. Why? Because you're supposed to take the biggest book that you have around the house, which usually is the Bible, and hit them. I don't recommend that, but sometimes that works. In general, unless they cause pain, unless they are increasing in size, or unless they are causing any type of functional impairment, I tend to tell people to leave them alone. But if they do any of those three things, then I would have it looked at. And also you want to make sure that it is a ganglion cyst. Obviously any type of enlargement that we see, we always tend to think of the worst things first and make sure that those things aren't present.
All right. This question is for Dr. Fernandez. I understand that MedStar does combine breast reconstruction after mastectomy. Can you describe that procedure?
So there are several different options for reconstruction after mastectomy. One is using implants. So a woman would go into the operating room for a mastectomy, usually for breast cancer, but sometimes prophylactic mastectomies for women at high risk for developing breast cancer. And then after the mastectomy part of the surgery was over, the plastic surgeon would come in and put what we call tissue expanders underneath the muscle that sits behind the breast. And over time, those expanders would be inflated larger and larger, and then final implants would be put in, usually 4 to 6 months after the mastectomy surgery. But that whole time, the woman would have mounds that were similar to the size of her breasts. It just wouldn't be the final implant. Another option for reconstruction after mastectomy is to use a woman's own tissue, which is called autologous reconstruction. And that procedure, normally we use the stomach tissue. So the fat and skin from the stomach is moved up to the defect on the chest wall. So in that case, when a woman wakes up from the surgery, she would have the final size breast.
Okay. We have another question. This one's for Dr. Walters. Can you develop IBS from a previous episode of an impacted bowel from surgery?
I think so. I mean, there's no studies that show really a direct result of these types of things. Usually if a bowel, if they got impacted, I would imagine that they were having something called an ileus after surgery, which is very common. It's called a post-surgical ileus, which just means the bowel is sleeping. So sometimes, especially under general anesthesia, their bowel doesn't function properly. And so, that may sort of trigger the symptoms that we've described. So yes, certainly I think it could develop after that.
Okay. Next question from our chat room. How do I know if I'm premenopausal?
Well, premenopause, and excuse me because my allergy eyes seem to be going here, is prior to menopause. So menopause is when you have a whole year with no period. So when you're premenopausal, we can expect that you may have hot flashes, that you may have less frequent periods, and unfortunately hot flashes can last a decade. So they really, spend a lot of time talking with people about them, treatment for hot flashes, alternative and prescription medications. But I would say the big thing I think is don't attribute abnormalities to your period to being premenopause, because I think we can miss polyps and cancers that way. If you have bleeding that's over 7 days, if you have periods that are getting really close together, less than 3 weeks from the first day of one period to the first day of the next, that can happen in your 40s, but that isn't really necessarily a menopause-like symptom. So you can expect that you might have night sweats and difficulty sleeping, and you might miss some periods. But if it gets excessive, close together, it could be something else, and you really want to get it checked out.
All right. I want to just remind everybody in our audience at home to keep the questions coming.
So I have a couple of questions. Since we're all here, I won't get them all together again. But this is a couple of questions that cardiac patients ask me, and I don't know how to answer them. One of them is hormone replacement therapy. There's pluses and there's minuses. I know what they say in the cardiac literature, but what is the general consensus about putting postmenopausal women on hormone replacement therapy?
I think the thought is that estrogen can be protective for the heart if it's given close to the time of menopause. But if you're giving it to someone who's through menopause in their later years, it may not be as protective. That when you're giving it to someone in their early 50s, maybe you're preventing plaque, but when you're giving it to someone in their 70s, maybe you're creating clot. So the studies that we commonly refer to are things like the WHI study that's over 10 years old. And they found that hormone replacement, which we used to think should be put in the water, might have some really negative effects. So estrogen alone can be used in someone that's had a hysterectomy, and that can be protective for the heart. But if you use estrogen with progesterone, you increase people's risk of heart attack, stroke, DVT in the leg, pulmonary embolism. So it's really interesting that I think that we have to look at the progesterone. We always get asked about the estrogen, but the progesterone is the question. Well, estrogen has some positives and negatives, but the progesterone actually may have a few more negatives.
Okay. Another question for you. I have been, actually it's for Dr. Fernandez. I've been hearing a lot about IORT. Does MedStar offer that, and what is it?
So IORT is intraoperative radiation therapy. So we started off talking about minimally invasive breast cancer treatments. When I mentioned breast conservation therapy, that's lumpectomy and radiation. So traditional radiation is 36 treatments of external beam radiation, and that lasts 6.5 weeks, Monday through Friday. The actual treatment takes less than 10 minutes, but the woman's usually there for about a half an hour. There's another type of radiation therapy which we give over a 5-day period, twice a day, and that uses a catheter that's being shown right now on the monitors. Through that catheter is placed in the surgeon's office, and through the catheter, the radiation seeds are delivered into the breast. So rather than giving external radiation, the woman will actually get radiation to the lumpectomy site, which is when breast cancer recurs after a lumpectomy, 85% of the time it occurs at the lumpectomy site. So there it's depicting the radiation seed moving through the catheters to treat that lumpectomy site. The newest, shortest form of radiation is IORT, or intraoperative radiation therapy, and that is available at 2 of our MedStar hospitals here in Baltimore. And that delivers the full dose of radiation in the operating room immediately after the lumpectomy, so that when the woman leaves the operating room, she's finished with her surgery and her radiation treatment.
Wow. Okay, here's one more for you. I had a lumpectomy for stage 1 breast cancer 3 years ago. I now take tamoxifen. The doctor recently said that I should stay on it for 10 years. Are there any contradictions for doing so?
So there's been some new studies showing that hormone blocking therapies such as tamoxifen and aromatase inhibitors are beneficial for longer time periods, and it's a very individualized decision to make. So with tamoxifen, there are concerns of the problems with endometrial hyperplasia and endometrial cancers and DVTs or blood clots in the legs, and that's something that we always monitor for. But what I say to that person is, if your physician recommended that for you, then in your specific case, it sounds as though you would benefit from the longer time period of hormone blocking therapy.
I have a question. As we move forward, and all of us have young women in our lives, what are some of the things that we can make sure they do, that they maintain a healthy lifestyle? For example, exercising early on is going to help them to have better bone health when they're older.
No, absolutely. And I think one of the commonalities that I've heard, and happens in orthopedics with arthritis, our studies show that women tend to hold on to their symptoms longer than men do. And I think cardiology said the same thing. And that I think women probably deal better with pain in general than men. And they tend to not want to disrupt the household maybe, but paying attention to symptoms early I think is very, very important. Certainly as far as bone health, exercise, weight control, all those types of things are very, very healthy in general.
And that goes across the board for all of your specialties, I would
Obesity
imagine.
increases the risk of breast cancer, and exercise decreases the incidence and risk. So it's very important in the breast cancer arena.
Too.
I think one of the things that we also didn't talk about is the epidemic of diabetes, which is blowing up in this country as well as all across the world. And there was a recent CDC estimate that maybe 1 in 3 Americans will have diabetes in the next 30 years. And that traces back to, again, healthy lifestyle and maintaining a normal weight.
I have another question. from our chat room. Barbara wants to know, when can I stop seeing an OBGYN? Does it ever end?
Never.
Well, there's certainly a lot of information about spacing out the pap smears now, and that perhaps at 65 or 70 you could stop doing a pap smear. However, the interesting part is then you have increased risk in things like ovarian cancer that starts to present. So I think you want to talk with your primary care. You want to remember that if you're having any excess irritation, any bleeding after menopause, after that 1 year without period, that you want to see someone. And if you have your primary care doing your breast exams and your mammograms and you agree that you don't want to see the OBGYN regularly, that's an option. But keep in mind, even the Medicare patients, they will cover for people to come in every 2 years, and we're living longer. We talked about women living longer. If Medicare starts at 65 and you're lucky to live as my grandmother is now at 93, well, that's a pretty long time where you might in your 80s consider doing surgery if there was a problem. And some of the cancers that we see, like uterine cancer, if caught early, are cured by hysterectomy, and maybe radiation isn't necessary. So I look at it as what's your function, what's your life expectancy, how healthy are you, and I think I'll be going for a little bit.
Can I just
Past menopause.
chime in on the breast exam?
Yes.
I think in so many cases it's the gynecologist that does the yearly clinical breast examination, which is recommended in women throughout their life. So if you do stop seeing your gynecologist, you need to make sure you're getting a clinical breast examination from your primary care provider.
Okay, we have about 4 minutes left. I want to invite you, the audience, just to ask a question, okay? Let's get those in.
This is for Dr. Khan regarding thyroid patients. For a patient with normal thyroid function test, but they have thyroid nodules, are they at higher risk for cancer, or what is the treatment plan for someone like that?
Sure. So thyroid nodules in general are also pretty common. There are some estimates that maybe 25 to 30% of the general population will have thyroid nodules. Nowadays, we're finding out more about thyroid nodules because frequently folks are getting CT scans and ultrasounds for various other reasons. The good thing is that 95% of thyroid nodules do tend to be benign. So the risk of malignancy in thyroid nodules is usually, we say, about 5 to 8%. And even in the worst case scenario, even if somebody does have thyroid cancer, you never want to have a cancer, but if there is any one to have, it's probably that one. Because in the hands of a good surgeon, essentially after thyroidectomy, which is the removal of the thyroid gland, most patients are essentially cured.
This question is for Dr. Gold. Last year I was training for Race for the Cure, and I had this spontaneous fracture of the tibia, and so didn't fall, nothing like that. And so it was fine. I'm back to cardio 3 days a week and horseback riding every week and so on and so forth. Would you think I was increased risk for osteoporosis? Is my skeleton falling apart, or is it just something that just happened?
What you're describing is probably a stress fracture that went on to a complete fracture, and we see that a lot in people that are training for endurance events, where the repetitive stress, the sudden buildup, the sudden ramp up of mileage is kind of an overload to the skeleton. However, you look too young to have osteoporosis, but I think that if there's been any other history of a fracture in your lifetime, it would not hurt to get a bone density test, because that could be a factor.
Okay, we have one more question back here I think we can squeeze in.
This is for Dr. Natlaga. What age would you recommend that a younger girl, 16, 17, 18, start having a GYN exam even if she's not sexually active?
Great question. I think that they're recommending, well, I know they're recommending the pap smear now to start at 21. But I think there's a time when we want to speak with people about birth control, about vaccination before they're sexually active. So Gardasil is a vaccination to prevent HPV, which can cause cervical cancer and STD, genital warts. Not something fun to say, but not something fun for people to have. So I think you do want to have someone in their teen years come in with an open conversation with the GYN, talking about birth control, talking about STDs, talking about exams, talking about the breast exam, So I would say it's different for each person, but I think my number is probably 16. We will see girls even at 12 if they're having period issues, but unfortunately I've seen 13-year-olds have babies, so it's different ages for different people.
Okay, that was a fast hour. I just want to thank everyone for participating, our audience at home, this fabulous panel of experts, and thanks to the president of MedStar Franklin Square Medical Center, Sam Moskowitz, for holding this Women's Health Forum tonight. It's been a great and informative evening. Thank you, everyone. Good night, everybody.